Bismillahirrahmanirrahim. So I just sent you a book on this topic, differential diagnosis in psychiatry. And this presentation is mostly picked up from that book. So I read the book and I made the presentation, and it's still not its complete, but I will try to do it. So if you want to refer back to anything that I'm missing here, you can always read that book. It's a good book. At least it gives an idea what to say and what to talk about things. Uh, since the time, I hope you can hear me clearly. When I was a trainee, my supervisors used to ask me the differential diagnosis, and we were supposed to say, after ruling out the organicity, I will consider the following. और फिर अगला सवाल ये होता था कि what organicity, and then we used to describe that we want to rule out this, whatever. Then after some time, this thing continued for a long period of time, but there was a debate in psychiatry considering the functional and the organic diagnosis. And this debate continued for almost 30 years. When we say that the psychiatric disorders are the functional disorders, and when there is a structural brain abnormality, then there is again, neurological disorder. So that debate continued. With DSM-5, things changed. Even with DSM-4, things changed a little bit, but not to an extent that it should be considered that practically speaking, this is how we should go forward. But with DSM-5, things changed. Now, this terminology, first, I will rule out organicity, is obsolete, and it should not be used because this is no term. We should move forward with things. After to rule out the organicity. Now, if you read the classification system, DSM-5, ICD-11, they are very explicitly clear about the things that most of the psychiatric disorders, they have some organic basis to it. What organic basis? Of course, it's on a neurotransmitter level, not as a structural level. But debate is now almost completed, and we all believe that there are definite changes in the brain system, neurotransmitters, neurochemicals, some abnormalities of, again, other areas which can cause the psychiatric morbidity. Even the social and the psychological impacts generating some of the psychiatric morbidity, they do have basis where there is definite changes in CNS. Am I clear? So all of you, when you will be appearing in the exam, will be using the diagnosis not to say that I will rule out the organicity or I will try to assess the organic brain syndrome. No, this should not be said. So now what should we say in front of the examiner, in front of our seniors? What should I say? Let's talk about some of these things. Whenever a patient comes to us and sits in front of us, we try to assess the patient by talking to them. First, of course, we talk. And then we are making our mind where to move forward, so that basically the presenting complaints, the history of present illness are the two components where we are actually trying to figure out what is wrong with this person and how we should proceed further with mental state, diagnosis, and other stuff. So there are times when everything may not be as it seems. Somebody coming and sitting in front of you, and they start talking about their problems, and then you realize that something is missing, something is not the way it should be. Of course, the justification and other stuff keeps on coming in when you keep on talking to them. But two conditions, the malingering and the fictitious disorder, although these terms have been removed now from ICD-11, especially malingering is removed from ICD-11, but DSM still uses it. And malingering and fictitious disorders, we have talked about the definition, the differences, blah, blah, blah. But the basic problem in these two things are differentiated on the basis of the motivation for the deception. So if the patient is communicating to you and the patient is not communicating his actual problems, but he is trying to pick up some problems and demarcate them, and there is an intent that this person, whoever the clinician is sitting in front of them, I can deceive them. Chakar de sakta. And when the motivation is the achievement of a clearly recognizable goal, the patient is considered to be malingering. And when the deceptive behavior is present, even in the absence of obvious external rewards, the diagnosis is fictitious. Now, these two things, why I want to keep them here and why they are kept in the book in the first place is that whenever you start interviewing a patient, talking to the patient, so in West, like in US, people do go to the psychiatrist to gain few things like छुट्टी लेनी या जॉब से कोई अगेन पैसे लेने हैं कि जी काम कर रहा था और वहां पे मशीनों का शोर बहुत था जिसकी वजह से मैं ट्रॉमेटाइज्ड हो गया हूं और मुझे $1 मिलियन जुर्माने में दे दिया जाए. Now, why are you using the words in Urdu? Because I don't want to communicate these things in English. So there is a motive behind seeing the doctor in the West. Of course, these things are relatively different. The presentations are relatively different in our culture. But we do see people coming from the jail, coming from various facilities where they have a motivation, like retirement benefits, premature retirement, getting benefits from the government. People do have motive there to see a psychiatrist and then move forward with it. So when you start talking to the person and you feel that there's something not appropriate, then you have to assess these two things. And if you'll be able to find a motivation of the person to see you, then malingering should be ruled out. And when there is no motive, the fictitious should be ruled out. And then you move forward. Now, why we should again raise the suspicion of being suspicious of being malingering or fictitious disorder, why I'm putting again it at the first place is that I have given you an example when there are clear external incentives to the patient being diagnosed with a psychiatric condition, for example, disability determinations, forensic evaluations, criminal cases, civil cases, and in prison settings. All of these settings, people do present to you with some kind of, again, symptoms because they want to gain something out of it. When the patient presents with a cluster of psychiatric symptoms that conforms more to lay perception of mental illness rather than recognized clinical entity, so they will give you the mixture of symptoms of maybe anxiety, depression, schizophrenia, and intellectual disability. Now, if all of these things are present in actual, then there has to be a correlative history related to the problems. So when supposedly a prisoner is coming to and you are assessing them, then you have a clear-cut history that he was born abnormal, there were some facial abnormalities or some intellectual abnormalities, led to the criminal activities, which led to some psychiatric morbidities, blah, blah, blah. So there has to be a link when we are taking the history from day one till the time they present to you. And when the nature of the symptoms shifts radically, like one time you went and you felt that this patient is probably having schizophrenia. And second time you went and you saw that this patient is suffering from depressive disorder. And this happens in the clinical settings in outpatient departments as well, not in the prison situation, but other settings as well. And you get confused that this person was given antidepressant and now he's presenting with absolute psychotic symptoms, self-talking, self-smiling, bizarre behavior, oddity. This seems like probably schizophrenia. Now, sudden fluctuations in these kind of the symptoms is actually practically possible as well, because sometimes the schizophrenia do present in the beginning with symptoms like this, depressive symptoms, and gradually evolve into schizophrenia. But then there is a link, there is a connection, and you are able to understand that. But when the patient has a presentation that mimics that of a role model, he has seen somebody, like what happens in our ward sometimes, that there are 5 people who are suffering from dissociative disorders or conversion disorders, and this was happening to me occasionally. And when I was going into the ward and I was seeing that one patient started having a seizure and all the rest of the 4 started having the seizure at the same time, and nurses were running to just control all of them. So this is not unusual. So you have to be absolutely clear about these things. And again, personality problems, which unfortunately have, most of the personality disorders have poor prognosis and outcome as well. They do have manipulative and suggestibility in their presentation. So the clinician should be absolutely clear. I'm not saying that you should start with the mindset that this patient is a drama. No, not at all. But you should have a clear thing in your mind that this patient is coming from this setting and there are possibilities. This patient is coming in outpatient department. He wants a leave for extended relief, say for 6 months, and then this is a motive behind it. So you have to be careful in assessing and evaluating the patient. Am I clear? Agreed? Anybody disagreed? Let me know. Okay, then further processing. So the first and the foremost thing that we always rule out in psychiatry is the substance abuse. In the presence of the substance abuse, most of the psychiatric symptoms, they can present with psychosis, they can present with depression, they can present with anxiety, they can present with OCD or anything. So the first and foremost thing is to rule out the substance abuse. This is what I have been teaching you for a long time as well. The first question that should always be considered in differential diagnosis is whether the presenting symptoms arise from substance that is exerting a direct effect on the central nervous system. Missing a substance etiology is probably the single most common diagnostic error made in clinical practice. So for all patients, all psychiatric inpatient, outpatient facilities should have urine toxicology facility with them. Here, when the patient comes in to the emerge, the first thing clinicians do, the emergency people, not to the psychiatrist, they do the urine tox. Urine toxicology is done, and most of the substances, so there are about, it depends how many filters you use, but ideally speaking, the commonly used substances are always used in a filter. So it can rule out benzodiazepine, cocaine, hash, heroin, opioids, blah, blah, blah. There's a long list, even the stimulants. So there is a list of approximately 54 various chemical substances that are actually ruled out in urine for toxicology. Minimum, which I have seen, is 11. And one of the laboratories in Lahore, privately, they were doing it. Initially, the cost was very less. It was just 500 rupees for the test. Now they have raised the cost because of the, again, so many other issues. But that is the first thing. So even when I was in Pakistan and practicing there, the patients, all the patients coming for any kind of the opinion, either from the court, from the jail, from the board, from the disability people, the first thing is get their urine, send it to the toxicology. And that report should be there. So the first and foremost thing is to rule out substance abuse etiology. That is clear. And to rule out the substance abuse, one, careful history, physical examination for signs of substance intoxication or withdrawal. Substance abusing individuals are notorious for underestimating their intake. It is usually wise to consult with the family members. So, a collateral information from somebody else, obtain laboratory analysis of the body fluids to a certain recent usage of drugs, and it should be remembered that the patient who use are exposed to any variety of substances. So when you are seeing somebody having a problem presenting to you in psychiatry, and you want to make sure that you have to move forward with it. So when in the exam situation, you want to move forward with it. Of course, the first slide, you won't say that I will rule out fictitious and malingering disorder first. But the first sentence is usually, I will rule out presence of substance abuse. I have taken the history. There are no signs as such and physical examination related to the substance abuse, toxicity, withdrawal, etc. However, I will still want to send urine for toxicology for analysis and to assess if there an objective account to assess if there is no history of substance abuse. This is the first differential. The first thing. So the first thing you will say in the exam situation when you are talking about differential diagnosis is to rule out substance abuse because that is unfortunately missed. Then the psychiatric symptoms result from the direct effect of the substance on the CNS, resulting in the diagnosis of substance-induced disorders in DSM-5 and of course ICD-11 as well, like cocaine-induced psychotic disorders, zerazepine-induced depressive disorders, things like that. There are so many other terminologies as well. And the substance abuse is a consequence or associated feature of having primary psychiatric disorder. So there is another possibility that the substance abuse is there, but the patient is suffering from actually primary psychiatric morbidity and the substance abuse came later on. Or the substance abuse and the psychiatric morbidity were going together simultaneously. All the relationship with the substance abuse you have to rule out. And this is what you'll be again saying in your initial statement in the exam. Once these effects have been removed by a period of abstinence after the withdrawal phase, the symptoms should spontaneously resolve. One, persistence of the psychiatric symptomatology for significant period of time beyond periods of intoxication or withdrawal of medication use suggests that psychopathology is primary and not due to substance abuse. The exceptions to this are substance-induced major or mild neurocognitive disorder or hallucinogenic persisting perception disorder. So some of these disorders, they can last longer despite taking away the substance from the system. So DSM-5 criteria for substance abuse medication-induced presentation suggest that the psychiatric symptoms be attributed to substance abuse if they remit within 1 month of the cessation of acute intoxication, withdrawal, or medication use. So 4 weeks time period. So if the patient is even in ICD-11, it's probably 6 weeks in ICD-11. I don't remember exactly, but just confirm it from your ICD-11. There is a clear-cut time period mentioned. If the person is taking substance abuse, having any kind of substances, and you are confused about the diagnosis, the primary diagnosis presentation is schizophrenia, but there is a history of substance abuse. Both are actually simultaneous. the onset of the symptoms and the substance abuse, or maybe the substance abuse was in the beginning and the symptoms developed later on. The first and foremost thing is 4 weeks of drug-free time period, which can be done at home, which can be done at work, which can be done in the hospital. Again, till the time your urine for toxicology is clear. It might make sense to use more extended duration or a shorter duration depending on your concern for avoiding false positive versus false negative with respect to detecting a substance medication induced presentation. So sometimes when a patient comes to me, I see them, I try to evaluate them, and I feel that this is schizophrenia. However, there was a history of substance abuse as well. And I feel that the relationship between the substance abuse and the development of the psychotic symptoms is actually not correlating with the diagnosis of substance-induced psychosis. So I should proceed with this, again, treatment of schizophrenia. But there has to be an evidence related to it. So in just doing this, you will definitely see the amount, the nature, the duration, and other things happening in patient's life. So patient said that he was having difficulty in concentrating when he was 16 years of age. By 18 years of age, he started having the self-talking and self-smiling. And at the same time, he started abusing hash as well. I will definitely try to rule out the substance abuse, but apparently there were some symptoms developing earlier to that as well. This is what a good history will suggest to me. And good history never means consuming too much time. Good history means very specific, precise, to the point things needs to be assessed. If you have good skills to assess that, this is what we have to learn in psychiatry to do this. And then we are a good psychiatrist. If those skills are missing, we are in trouble. So consider the presentation, consider the correlation, consider the episodic relationship, consider the family history, consider the objective account, consider the, again, laboratory investigations and your physical examination as well. All of these things will definitely lead you to, okay, fine, I have sufficient evidence that this person is having substance abuse and the symptoms were generated at the same time. So I will wait till the time the substances are clear before I will label him schizophrenia. And this is what precisely you have to say in the exam. Are you people clear? Any confusion about it? So the first and the foremost thing that in the exam situation you will say is that I have assessed the patient. I have significant evidence that there is no history of substance abuse. So the primary diagnosis is schizophrenia, if you want to say like this. Or another way of saying it, I have assessed the patient. I have my reservations. I need more account. I need subjective account. I need objective account, observation, urine for toxicology before I will commit to the final diagnosis of my differential diagnosis in psychiatry. So the substance abuse is the first thing. This is what you have to say in exam and in front of your seniors when you are presenting a long case. The first sentence in the differential diagnosis. Are you people clear about it? Any question? No? Sure. Manur, you have raised hand. Go ahead.
यस सर, मेरा एक क्वेश्चन है, जैसे आप ऑर्गेनिसिटी का पहले बता रहे थे कि हम अभी तक हमारी भी यही प्रैक्टिस है कि हम हमेशा बोलते हैं आफ्टर रूलिंग आउट ऑर्गेनिसिटी.
गलत प्रैक्टिस है, गलत काम तो
नहीं, मैं आपसे यही
आगे निकल गई. हम पाकिस्तानी अभी भी शिजोफ्रेनिया बोलते हैं. नो सर, say that.
Okay.
I'll be angry. I will fail you.
I won't say that again. Don't worry.
Just giving you an example, right? So we have to move with the times. Yes, go ahead with your question. Sorry.
सही तो वो ठीक है, जैसे आपने बता दिया कि वो सही प्रैक्टिस नहीं है, तो अब ये जो आपने सब्सटेंस यूज का बताया है, ये क्या हर केस में इसको मेंशन करना जरूरी है? अगर सब्सटेंस यूज की हमें कुछ मिल ही नहीं रही, कोई हमें फाइंडिंग मिल ही नहीं रही, अगर हम फिर हम क्यों मेंशन करें?
फिर भी बोलना है आपने. I have assessed the patient. I have tried to rule out the possibility of substance use disorders. I could not find any evidence related to this. So my primary diagnosis आगे. Yes, हर केस में differential diagnosis जब आप पहुंचेंगे formulation में या exam में, जब आपसे examiner कहता है what is your differential diagnosis, you will say this word. First, I tried to rule out the possibility of the substance abuse. There is no correlation or history. So I have ruled out the substance abuse. And after ruling the substance abuse, I will consider the diagnosis of anxiety disorder, schizophrenia, alcohol use, depressive symptomatology, or psychiatric disorder and substance abuse relatively independent of each other, whatever is the situation. आया जवाब? ओके, अगर हो गया तो हाथ नीचे कर देना. एनी अदर क्वेश्चन?
मेरा इसमें क्वेश्चन ये है कि ये हो गया ना कि जिसमें नहीं है सब्सटेंस यूज या जिसमें ऑर्गेनिसिटी नहीं है. फर्ज करें कि एक पेशेंट में सब्सटेंस यूज है.
ਹੁਣ ਤੂੰ ऑर्गेनिसिटी ਦਾ लफ्ज बोलिया तो फिर ਇੱਥੇ मैं ऐसा टांगा.
सर अभी हमारे सिस्टम से निकलते निकलते तो टाइम लगेगा, बड़ी मुश्किल से हमें सिखाया.
हमारे सिस्टम से इसको निकल जाना चाहिए, बस अब खत्म कर दो.
अच्छा, मेरा क्वेश्चन ये है कि फर्ज करें आप हमें सब्सटेंस यूज मिल गया, उसके बाद फिर क्या हम अपने साइकाइट्रिक डिफरेंशियल्स देंगे या नहीं देंगे? क्योंकि फिर तो
आई एम कमिंग टू इट, बिल्कुल देंगे. अच्छा. लेकिन आप पहला जुमला ये बोलेंगे कि आई हैव असेस्ड द पेशेंट, द पॉसिबिलिटी ऑफ द सब्सटेंस अब्यूज इज देयर, so I will further investigate with urine for toxicology and objective account. However, proceeding further, my diagnosis, the list of differential diagnosis includes. ये मैं जुमला बार बार इसलिए मुख्तलिफ तरीकों से बोल रहा हूं कि this is how you have to say it in the exam and in the long case now.
ठीक है.
Right? हर तरीके से मैं कोशिश कर रहा हूं कि मैं उस जुमले को कवर कर दूं. अगला जुमला, ये जुमला पहला जुमला हो गया. दूसरा जुमला, rule out a disorder due to general medical condition. What you are saying that organic. No organic. It's general medical condition. Even in ICD-11 and DSM-5, both, it's again medical condition. General medical condition covers most of the things and it's a safe term to be used. So using this terminology will be fine. Organic rule outs in psychiatry. The organic rule outs in psychiatry are called general medical condition, in which the clinician is asked to first consider to rule out physical causes of the psychiatric symptomatology. Hyperthyroidism, hypothyroidism, right? Metabolic syndromes, hyperlipidemia, congestive cardiac failure leading to mild cognitive impairments, blah, blah, blah. So there are so many things related to it.
Anemia, sir.
Anemia. Yeah, there are so many things, right? But you will not say organic. You will say, I will rule out the general medical condition related to this differential diagnosis and presentation. I have ruled out the possibility of substance abuse. I will try to assess him for a general medical condition related to this psychiatric morbidity like hyperthyroidism, anemia, blah, blah, blah. And after ruling that out, I will proceed further. Now, 4 reasons the differential diagnosis can be difficult to present. Again, general medical condition. 1, symptoms of some psychiatric disorders and many general medical conditions can be identical. Symptoms of weight loss and fatigue can be attributed to depressive and anxiety disorders or to a general medical condition as well. Sometimes presenting symptoms of general medical conditions are psychiatric in nature, like a patient presenting with actually sadness of mood could have a pancreatic cancer or a brain tumor. So these are complicated situations. The relationship between the general medical condition and the psychiatric symptoms may be complicated. And again, because which came first? He's suffering from diabetes and having peripheral neuropathy, but he is presenting with the depressive symptoms mostly. So should I treat depressive symptoms, or should I send him to endocrinologist and neurologist to treat the neuropathies? Yes, sometimes these things are difficult. And patients are often in settings primarily geared for identification and treatment of mental disorders. Aapke paas aaya hai, so he is actually asking you for help to treat the depressive symptoms. And you feel that the depressive symptoms could be related to neuropathy or again some other thing. So usually some few things are unfortunately complicated. Virtually any psychiatric presentation can be caused by direct physiological effects of general medical condition. Any symptom, dissociative, hystericals, adjustment disorders, grief reactions, anything is a possibility that there is some simultaneous generation of a general medical condition leading to these symptoms, which may be complicated. So the second line that you will say in presentation would be, I have ruled out the possibility of the substance abuse in this patient. However, I will still would like to go for urine for toxicology and objective account to ensure that there is no substance abuse. I will rule out the possibility of general medical condition. I have asked relevant questions. Still, I will go for certain investigations to ensure that I am not missing the link. This will be the second sentence. There are 5 relationships, etiological relationships. The general medical condition causes the psychiatric symptoms through a direct physiological effect on the brain. 2, the general medical condition causes the psychiatric symptoms through psychological mechanisms. Like if I'm having, say, plantar fasciitis, I cannot walk properly, then these things are actually generating anxiety in me. Why I am not able to walk properly. And so there is a possibility that it is a consequence, right? Then the medication taken for general medical condition, like there are so many medications that I don't want to talk about them, and they may lead to some psychiatric symptoms. Then the psychiatric symptoms can cause adverse effect on general medical condition. If a person is depressed, we all know. If a person is anxious, if a person is sensitive, hypertension will not be controlled till the time you'll be able to control the psychiatric symptoms. This is unfortunately true, and we all know this, so I won't go into the details, but this is what the correlation is. And the psychiatric symptoms and the general medical conditions are coincidental. For example, hypertension and schizophrenia both happened at the same time, or he developed the schizophrenia, he was having schizophrenia, and the treatment of schizophrenia since for past 20, 30 years, he reached the age of 44 and he developed hypertension. So comorbidities do exist. And we have to, again, be very specific about these. So the second sentence in presentation of, again, the same situation, what I am discussing earlier is, 1, I will rule out the possibility of the substance abuse, make further necessary, again, inquiries and my account so that I'll be sure that there is no history of substance abuse. I have tried to assess for the general medical condition, although I could not find any correlation. However, I will still go for certain investigations to rule out the possibility of this. 3, 4, 5, whatever you want to say, right? And then you will further proceed with next, a specific primary psychiatric disorder, and differentiate adjustment disorder from residual disorders, specific disorders, unspecified disorders. So this is how you will move forward. And then the primary psychiatric disorder will come in. Any question so far? No question?
Sir, I have a question.
हाँ बोलो.
सर अगर हम केस प्रेजेंट करें और जैसे आपने कहा है पहले सब्सटेंस यूज को रूल आउट करके जनरल मेडिकल कंडीशन को रूल आउट करके फिर हम अपना डायग्नोसिस देंगे, अगर हमारे जहन में कोई जनरल मेडिकल कंडीशन आ नहीं रही से रिलेटेड तो फिर
ये कैसे हो सकता है? अगेन हर साइकाइट्रिक डिसऑर्डर के साथ एक जनरल मेडिकल कंडीशन को याद कर लें.
मतलब सर फॉर एग्जांपल हम स्किज़ोफ्रेनिया के साथ हम क्या याद?
हाँ, स्किज़ोफ्रेनिया के साथ आप 5 चीजें डेफिनेटली देख लें. स्किज़ोफ्रेनिया का ऑनसेट होता है आमतौर पे एज 20 के आसपास, राइट? वी ऑल नो दिस. सो एज 20 के आसपास फिजिकल कंडीशंस कौन कौन सी हो सकती हैं? 1, ट्यूमर, ट्यूबरक्लोसिस और chronic infections. Rule out chronic infections, rule out any tumor, rule out any possibility of endocrinological disorders like hyperthyroidism, hypothyroidism, which are unfortunately again common around the age of 20s, teen, chauthi kaun si thi? Okay, and then possibility of juvenile diabetes and other things can be related, and there were 2 more. I will definitely let you know, but you should try to see the age of onset of an illness, psychiatric morbidity, and what other physical morbidities can present at the same age. Like depressive symptoms, we all know usually begins around 25 to 35. 25 से 35 साल की उम्र में जो साइकाइट्रिक मॉर्बिडिटीज हो सकती हैं रूल आउट कर लें. फीमेल पेशेंट है, आप उसको मेनोरेजिया है, गायनोकोलॉजिकल डिस्टर्बेंसेस है, ओवेरियन सिस्ट हैं, ट्यूमर्स है, इस तरह की 4-5 याद कर लें.
सर नहीं, मेरा क्वेश्चन फिर भी अपनी जगह है. फॉर एग्जांपल इफ वी से 20 इयर्स में किसी को स्किट्स का ऑनसेट हो रहा है एंड इफ वी टॉक अबाउट ट्यूमर, अगर हमें हिस्ट्री में कोई ट्यूमर वाली फाइंडिंग मिली, हिस्ट्री मिली नहीं रही, तो फिर हम कैसे ट्यूमर कहेंगे?
इसलिए कहेंगे पहली बात कि 20 दिन की हिस्ट्री में स्किज़ोफ्रेनिया नहीं डायग्नोज होता. that is only diagnosed if the symptoms are persistent for more than 6 months in ICD-11 and DSM. 6 महीने की हिस्ट्री चाहिए.
सर आई रीकन्फर्म ICD-11 में शायद 1 मंथ है. आई रीकन्फर्म.
चलो अगर 1 महीना भी है तो 2-3 हफ्ते तो नहीं हो सकते. सो अगर 1 महीने से साइकोटिक सिम्टम्स चल रहे हैं, आपको कोई एविडेंस नहीं मिला कि कुछ है, यही बोल दें. आप 20 साल की उम्र में ऑनसेट हुआ है, 1 महीने की हिस्ट्री है, आप कहें जी आफ्टर रूलिंग आउट द सब्सटेंस अब्यूज I have tried to assess him. I was not able to find any significant general medical condition which can actually generate these kind of symptoms. So my primary diagnosis is number 1, schizophrenia, number 2, delusional disorder, number 3, move like that.
ओके सर, थैंक यू. बस मेरा ये बहुत मेरे जहन में हर वक्त कंफ्यूजन रहती है कि अगर हमें
कोई कंफ्यूजन नहीं है. अगर नहीं मिला, say the sentence.
Okay. Right.
The sentence should always be said.
Okay,
In differential diagnosis, first substance abuse, second general medical condition. कुछ नहीं मिला, कहीं I was not able to find any significant correlation between these symptoms and a general medical condition which can correlate with this existing situation. However, I still would like to go for some relevant investigations.
Okay.
जो कि आपने बाद में बोलनी है लॉन्ग केस में कि आप क्या क्या इन्वेस्टिगेशंस कराएंगे. वो जो जिनको आप बेसलाइन इन्वेस्टिगेशंस बोलते हैं, वो भी गलत जुमला है. बेसलाइन इन्वेस्टिगेशंस कुछ नहीं होती.
सर वो नहीं बोलते,
हाँ
वो नहीं बोलते, वो आपसे सीख के.
अच्छा, बेसलाइन नहीं, इन्वेस्टिगेशंस हैं. जो इन्वेस्टिगेशंस हैं वो आपने बोलनी है. आई विल गो फॉर CBC with platelet counts, urine complete examination, thyroid profile or lipid profile or HbA1c or whatever you want to get that done. So it has to be specific. If you feel that there is no need for the investigations, there is no need for any actually investigation in the patient, I don't agree with you then. You are failed.
Mm.
As a
Sir,
clinician, as a psychiatrist, we need, again, यहाँ मैं use करूँगा baseline investigations का लफ्ज, we need certain parameters to ensure that over the period of time, those parameters won't be changed with medication. So like lipid profile. If a patient is suffering from schizophrenia, I will definitely assess him for his BMI and relevant investigations like diabetes, lipid profile, thyroid profile, anything that can have an effect, like electrocardiogram, anything that may be compromised because of my treatment interventions. I will still go for those investigations. And I will definitely try to go for further investigations in 6 months to a year's time, because I have to assess him for metabolic syndrome over the period of time. I don't want my patient to die of diabetes developing secondary to risperidone that I was prescribing him to treat schizophrenia. So there are no as such word baseline investigation, but there is an investigation which I have to keep on assessing him over the period of time. Clear?
Yes, sir, clear. One more question.
Go ahead.
सर जैसे भी हम ये लॉन्ग केस की बात कर रहे हैं, सब्सटेंस रूल आउट करने वाला, ये थोड़ी सी क्लिनिकल आपसे पूछने लगी हूँ बात। जो हमारे पास पेशेंट्स एडमिट होते हैं हमारे वार्ड में, अब स्किज़ोफ्रेनिया ही मेरे जहन में आ रहा है इस वक्त। फॉर एग्जांपल अगर कोई पेशेंट एडमिट हुआ है विद स्किज़ोफ्रेनिया और हम जब उनसे बात करते हैं उन पेशेंट से और हमें हिस्ट्री पे या कोलेक्चुअल इन्फॉर्मेशन पे कोई सब्सटेंस यूज़ की फाइंडिंग नहीं मिलती, तो जनरली वी डोंट गो फॉर टॉक्सिकोलॉजी टेस्ट। तो फिर वैसे हमें आइडियली करवाना चाहिए टॉक्सिकोलॉजी?
बिल्कुल आइडियली करवाना चाहिए, आइडियली करवाना चाहिए, और एग्जाम में भी आइडियली आपको बोलना पड़ेगा।
जी जी सर।
आप वार्ड में नहीं करवाते, ठीक है, फाइन, बिकॉज हर जगह होता नहीं है, राइट, और उसमें प्रॉब्लम्स हैं। अब यूरिन फॉर टॉक्सिकोलॉजी जो है उसके 5,000 रुपए का अगर वो टेस्ट है और वो 5,000 रुपए का टेस्ट पेशेंट नहीं करवा सकता, तो आप बहुत सारी जगहों पे केयरफुल होते हुए, पेशेंट को बेनिफिट देते हुए आप नहीं टेस्ट करवाते, बट एग्जाम में आपने बोलना है।
या गॉट इट, थैंक यू सर।
एग्जाम में इस पे कॉम्प्रोमाइज नहीं करना, ताकि आप एग्जामिनर को कोई मार्जिन ना दें कि वो बाद में आपको उस पे फंसाए। वो डेफिनेटली अगला सवाल इस पे यही पूछेगा, जब आप ये सारी चीजें बोलेंगे जो मैं बोल रहा हूं कि आई विल रूल आउट द सब्सटेंस अब्यूज, I may go for the urine for toxicology. The next question would be, what do you mean by urine for toxicology? And you will tell them that the urine for toxicology is a test which rules out most of the substances depending upon the number of the filters they have applied or utilized. Minimum is 11 number of the various chemicals that can be assessed, and the maximum is actually 54. They can assess for more than that as well. I don't know, but I know that this much, that there is actually above 50 substances that can be ruled out, because all of them are usually excreted from the urine. And it's a very simple test. Give the urine sample, put the filters there, and get it assessed. It's not a complicated test. Clear?
Okay, sir. जी sir. जी.
Good.
Thank you.
Any confusion? Any confusion? No? Okay. Now, these are the algorithms actually, which are on the basis of, again, DSM-5. It's not related to ICD-11 because I picked it up from there, like in delusions, substance intoxication, delirium, substance withdrawal, delirium-induced medication, medication-induced delirium, substance medication-induced psychotic disorder, substance intoxication, substance withdrawal, other adverse effects of medication, delirium due to another medical condition. All of these first four, they are actually the substance abuse and a general medical condition which can actually give rise to delusions. So any patient with a delusion, this is just an example, one example. We'll go through all the algorithms again next time. But just to ensure that if a person is presenting with delusions, these are the four things at the top. And you have to tell them, you have to say them, you have to talk about them before presenting your long case. Clear? Anybody, any confusion? सब ठीक है, सब अच्छा है, ओके। अगर सब अच्छा है तो फिर हम यहाँ पे रोकते हैं, ठीक है? बिकॉज अगर मैं अगला शुरू कर दूंगा तो फिर वो लंबा हो जाएगा, सो देन वी वोंट बी एबल टू। बट क्वेश्चंस कोई हैं तो पूछें। फॉर दिस आर यू क्लियर अबाउट इट? जी डॉक्टर मसूद,
सर मेरा ये क्वेश्चन है कि हम पहले जो यूज करते थे तो कुछ ICD-10 की हाई ER की थी जिसमें ऑर्गेनिक पहले आता था और ये ड्रग्स दोबारा आते थे, तो वो अब हम नहीं यूज करेंगे। जो है ना,
वो 32 साल पुरानी है, वो मेरे साइकियाट्री में आने से पहले रिलीज हो गई थी, भूल जाओ उसको। मेरे बाल सफेद हो गए, मैं अब रिटायरमेंट की एज के करीब पहुंच गया हूँ, छोड़ दो ICD-10 को, उसका पीछा। अब बोलो उसको, हाँ बोलो आगे क्या, सॉरी मैंने इंटरप्ट कर दिया, पूछो क्वेश्चन क्या पूछो।
सर यही क्वेश्चन था कि अब वो नहीं यूज करेंगे, ये यूज करेंगे?
बिल्कुल भी नहीं करेंगे, एग्जाम में तो आप बिल्कुल ना करना, क्योंकि अब आपके एग्जामिनर्स भी एक्सपोज्ड हो गए ICD-11 को। मेजॉरिटी ऑफ द एग्जामिनर्स ने ICD-11 देख ली, सुन ली, और अगर एग्जामिनर अभी भी ICD-10 पे पूछते हैं आपको, then it's not justified. You should report it to the college in your feedback after the exam. आप दो डायग्नोस्टिक क्राइटेरियाज नहीं याद कर सकते, प्रैक्टिकली पॉसिबल ही नहीं है, मेरे लिए भी पॉसिबल नहीं है कि मैं DSM-5 का भी क्राइटेरिया याद करूं और ICD-10 का भी याद करूं और अब ICD-11 का भी करूं। जस्ट यूज वन। अब अपनी आदत बनाएं, ICD-11 को यूज करें और एग्जाम में भी ICD-11 ही यूज करें, फुल स्टॉप। No compromise on any other thing. सबसे recent मोस्ट है, हर चीज कवर कर रही है, ठीक है?
जी सर, क्लियर।
गुड। एनीबडी एल्स? नहीं? ओके। वालेकुम सलाम जी, सॉरी
सर मेरा क्वेश्चन ये है कि सर जैसे आपने कहा कि फॉर एग्जांपल जैसे डॉक्टर मांगूर पूछ रही थी कि स्किज़ोफ्रेनिया ही है आपकी थ्रू आउट जो क्लियर कट हिस्ट्री है, लेकिन फिर आपने कहा कि फिर भी आप डिस्पाइट ऑफ जनरल मेडिकल कंडीशन को आप बताएंगे, जैसे ट्यूमर हो गया।
एक चीज ये भी याद रखना, साइकियाट्री में कोई चीज भी क्लियर कट नहीं है, इसीलिए तो सारे फिजिशियंस और एंडोक्राइनोलॉजिस्ट और गैस्ट्रोएंटरोलॉजिस्ट हमारा मजाक उड़ाते हैं।
यस सर।
साइकियाट्री में कोई चीज भी क्लियर नहीं है और साइकियाट्री में कोई चीज भी एब्सोल्यूट नहीं है।
यस सर।
आपका जो डायग्नोस्टिक क्राइटेरिया है ना स्किज़ोफ्रेनिया का, उसमें भी आप देखो ना, तो यही देख लो ना, सब्सटेंस अब्यूज पहले रूल आउट करना है, जनरल मेडिकल कंडीशन रूल आउट करनी है, फिर आपने अंदर डायग्नोस्टिक क्लासिफिकेशन में कोई हेलुसिनेशन नहीं मिल रही, कोई डिल्यूजन आपको नहीं मिल रहा, फिर भी स्किज़ोफ्रेनिया का डायग्नोसिस आप बना सकते हैं ऑन द बेसिस ऑफ सोशल एंड ऑक्यूपेशनल डिक्लाइन और सम अदर पैरामीटर्स। क्लियर कुछ नहीं है, ठीक है, और स्ट्रेट नहीं है, इसलिए हमें एग्जाम सिचुएशन में एज अ कैंडिडेट सेफ प्ले करना है। एग्जाम इज अ कॉम्प्लेक्स एवेलुएटिव प्रोसेस जहां पे हमें सेफ खेलना है, और सेफ खेलने में जब अपनी आदत बना लोगे ना, ICD-11 की एग्जाम तक उसको पढ़ के याद करके या एटलीस्ट उसके बारे में फेमिलियराइज होके, तो बाद में भी वो हैबिट्स आपकी कंटिन्यू हो जाती हैं। दिस इज हाउ द ग्रूमिंग प्रोसेस कंटिन्यूज। मैं इसलिए कह रहा हूँ वी शुड बी capable of accepting the challenges and take away the new roles। जब हमें क्लियर कट पता चल गया कि कैरिप्रोजीन अब D3 न्यूरोट्रांसमीटर्स पे इफेक्ट करती है, तो फिर हमें ये भी क्लियर पता चल गया कि जो माजी में बात की जाती थी कि स्किज़ोफ्रेनिया जो है वो नाइग्रोस्ट्राइटल और डोपामिनर्जिक D1 और D2 के पाथवेज पे होता था, उसमें मॉडिफिकेशन आ गई है। अब D1 और D3 और न्यूरोट्रांसमीटर भी है, और खाली D3 की एबनॉर्मेलिटी से भी स्किज़ोफ्रेनिया डेवलप हो सकता है। तो चीजें चेंज हुई हैं, उनको एक्सेप्ट करें, उनको मूव फॉरवर्ड लेकर चलें। ठीक है, चलो अगले जुमे को फिर मिलेंगे इंशाल्लाह। और मैंने कहा कि मैं रीस्टार्ट कर दूं, वरना आज भी क्लास रह जाती और फिर मैं फंस जाता। So we'll meet again next Friday and continue with this differential diagnosis. And I have the list of the topics now that I have to cover. So कोशिश करूंगा कि ये वाले टॉपिक्स जितने आप लोगों ने बताए हैं अगले 2-4 महीनों में हम इसको करें। ठीक है, थैंक यू, अपना ख्याल रखिएगा, अल्लाह हाफिज।
हेलो हेलो सर, उस बुक का नाम बता दीजिएगा।
किसका?
सर वो जो आप डिफरेंशियल डायग्नोसिस की बुक बता
बेटा
रहे थे,
इसी पे ग्रुप में मैंने भेजी है, वो इसी ग्रुप में भेजी, मैं रीसेंड कर रहा हूँ। डॉक्टर साहब, डॉक्टर मानूर उसको रीसेंड कर दें प्लीज।
ओके सर। सर एक और भी क्वेश्चन है।
हाँ गो अहेड
सर मेरा है।
हाँ गो अहेड।
अच्छा सर, मेरा क्वेश्चन ये है कि मुझे जो चीज सबसे ज्यादा कंफ्यूज करती है, देखें जैसे हम कह रहे हैं कि एक पेशेंट को स्किड्स है, तो वो जब हम कह रहे हैं कि पेशेंट को स्किड्स है, इसका मतलब है कि हम ये समझते हैं कि
स्किज़ोफ्रेनिया है। क्या है?
स्किज़ोफ्रेनिया है सर।
हाँ, स्किड्स नहीं बोलना, ना स्किड्स बोलना है ना शीजो बोलना है।
ओके सर।
और अब क्लियरली ये लिखा गया है तमाम बुक्स में कि हम ये नहीं बोलते कि दिस पेशेंट इज सफरिंग फ्रॉम स्किज़ोफ्रेनिया, हम बोलते हैं कि दिस पेशेंट इज हैविंग अ डायग्नोसिस ऑफ स्किज़ोफ्रेनिया। ठीक है, ये भी थोड़ी सी स्टिग्मेटाइजिंग स्टेटमेंट जो है ना, उसको खत्म करने के लिए। बहरहाल हाँ, क्वेश्चन क्या है?
जब हम एक पेशेंट को स्किज़ोफ्रेनिया है, तो इसका मतलब है कि हम ये समझते हैं कि सिम्टम्स किसी जनरल मेडिकल कंडीशन की वजह से नहीं है और सब्सटेंस यूज की वजह से नहीं है, क्योंकि वो तो क्राइटेरिया स्किज़ोफ्रेनिया का ये बताता है कि वो आपने इटसेल्फ रूल आउट करके ये बनाया है। तो इसके अलावा फिर
बनाया है, लेकिन वो आपने बनाया है, लेकिन जब आपने एग्जाम में प्रेजेंट करना है तो उस वक्त तो आपको प्रेजेंट करते वक्त तो ये बोलना पड़ेगा ना कि आपने ये क्राइटेरिया क्यों मेंशन कर रहे हैं। तो वहां पे वो दो चीजें आपको मेंशन करनी पड़ेंगी। हाँ, वैसे नोट्स में जब आप लिखते हैं तो आप अंडरस्टैंडेबली, जैसे नोट्स चल रहे हैं, आपने टेस्ट भी करा लिया, हिस्ट्री भी ले लिए, तब भी आपको मेंशन तो करना पड़ता है कि आपने जो है वो सब्सटेंस अब्यूज और जनरल मेडिकल कंडीशन रूल आउट कर लिए, तब आपका डायग्नोसिस स्किज़ोफ्रेनिया। चाहे कि डायग्नोस्टिक क्राइटेरिया में वो दो चीजें मेंशन है, बट उन दो चीजों का मेंशन करना भी जरूरी है।
ठीक है,
ठीक है, हो गया, चलो ओके, अल्लाह हाफिज, सी यू नेक्स्ट फ्राइडे इंशाल्लाह।
थैंक यू सर, थैंक यू।